Next, I will address how MASLD has evolved from the ghost of NAFLD. In 1980, Ludwig et al. Described a case series of obese diabetic female patients with fatty liver, lobular hepatitis, inflammatory infiltrates, Mallory bodies, and variable severity of liver fibrosis. As the disease was not related to alcohol, they termed it as non-alcoholic steatohepatitis, the NASH. The term non-alcoholic fatty liver disease, the NAFLD, was coined in 1986 to represent the occurrence of fatty liver in the absence of alcohol and other causes of fatty liver, a diagnosis of exclusion. The staging of NAFLD, based on liver histology findings, were proposed by Brunt et al. In 1999 and including evaluating severity of steatosis, ballooning, lobular and portal inflammation as mild, moderate and severe, and perisinusoidal and periportal fibrosis as stage F0, F1, F3 and F4. Thus, NAFLD was divided into non-alcoholic fatty liver called NLF with 3 grades when the liver contained fat without hepatitis. Non-alcoholic steatosis was applied when liver histology showed fat, ballooning and inflammation, each in 3 grades, along with liver fibrosis from F0 to F4. Cirrhosis demanded the presence of established nodules and complications associated with it. NAFLD is an original term that became a catchy name in society, was well accepted by the community, and has fostered tremendous research over the years. Over the years, an association of NAFLD with metabolic syndrome was established. Metabolic syndrome is a cluster of metabolic factors that include abdominal obesity, impaired blood glucose, high blood pressure, high triglyceride levels and low HDL levels, and insulin resistance. The criteria for each cardiometabolic factors in adults and children have been well defined and are depicted in this table. HOMA, developed by Professor David Matthews from the University of Edinburgh in 1985, is to study the interaction between glucose and insulin. It is calculated by taking fasting glucose, blood glucose, and fasting plasma insulin, or C-peptides if you are on insulin. A HOMA-IR value of more than 2.5 indicates insulin resistance in adolescents and adults, providing maximum sensitivity and specificity in diagnosing metabolic syndrome in both genders as per ATP3 and IDF criteria. Over the years, the criteria for diagnosis of NAFLD had to be reevaluated for several reasons. The pathophysiology of NAFLD had become well known over the years, and its association with cardiometabolic risk abnormalities had been established. Therefore, a diagnosis of fatty liver could be made based on inclusion criteria. Interventional studies on NAFLD required serial invasive liver biopsies, which limited progress. Several tools, particularly biomarkers and imaging, have become available to evaluate liver fibrosis and could replace the invasive liver biopsy for staging and intervention studies. The term alcoholic and fatty carried a stigma which needed to be replaced by a non-stigmatic term. In 2020, experts from Asian Pacific region introduced the term Metabolic Dysfunction-Associated Fatty Liver, the MAFLD. Diagnosis of MAFLD was accepted if a subject with fatty liver had 2 of the 5 abnormal cardiometabolic risk factors, including abdominal obesity, impaired blood glucose, high blood pressure, high triglyceride level, low HDL levels, high sensitive CRP, and insulin resistance. However, the term MAFLD had several issues. The term NASH and its role in the fatty liver disease was not included. The role of other causes of fatty liver disease and moderate alcohol intake associated with fatty liver disease also was not addressed. The inclusion criteria included 2 cardiometabolic factors for diagnosis. C-reactive proteins and HOMA-IR were also included, which are not routinely tested in patients of fatty liver disease. The stigmatic term fatty had not been eliminated from the definition. In 2023, a multi-society effort involving 264 experts from 56 countries, devised a new nomenclature of fatty liver disease through a comprehensive Delphi consensus process. Based on this, metabolic dysfunction associated with steatotic liver disease, the MASLD, emerged. The diagnosis of MASLD was accepted if a subject with hepatic steatosis had one of the 5 abnormal cardiometabolic risk factors, including abdominal obesity, impaired blood glucose, high blood pressure, high triglycerides, and low HDL levels. High sensitive CRP and HOMA-IR were not included. NASH was designated as Metabolic Dysfunction-Associated Steatohepatitis, the MASH. Associated moderate alcohol with fatty liver disease as metabolic dysfunction and alcohol-associated liver disease, the MAFLD. Cardiometabolic risk factors were more inclusive. Only one of the 5 was needed to label the patient with MASLD. The term steatotic was to replace fatty to remove stigmatization with the term. The most significant process in the new terminology was the exclusion of liver biopsy in the diagnostic algorithm for fatty liver disease. Diagnosis, classification, and grading of fatty liver were based on imaging, biomarkers, and elastography. Liver biopsy is now rarely needed and indicated in patients whose diagnosis of fatty liver disease is in doubt or where there is a discrepancy between various diagnostic tools. So, ladies and gentlemen, fatty liver disease now has a new terminology and classification as shown in this slide. Steatotic liver disease was chosen as the overarching term to encompass the various etiologies of steatosis. Non-alcoholic fatty liver disease will now be Metabolic Dysfunction-Associated Steatotic Liver Disease, MASLD. Metabolic Dysfunction-Associated Steatohepatitis, MASH, is the replacement for NASH. A new category outside pure MASLD, termed MAFLD, was selected to describe those patients of MASLD who continue some amount of alcohol per week. Patients with fatty liver disease in the absence of cardiometabolic risk factors will be designated as cryptogenic steatotic liver disease. While global consensus on the matter is still awaited, the latest nomenclature may provide a robust framework for clinical practice and further research. So, I urge you as medical professions to say goodbye to NAFLD, leave this in the hall, and welcome the new kid on the block waiting for us at the gate. Most hepatologists believe that the evolution of terminology in fatty liver disease has distinct advantages in clinical medicine and has simplified the diagnostic algorithm. Diagnosis starts with recognition of hepatic steatosis on imaging, usually abdominal ultrasound. Patients were defined as having steatotic liver disease. They are classified into several subgroups based on any of the cardiometabolic risk factors and other cause of liver disease.